I'm going to introduce Dr. Pratik Pandharipande, and he's a professor of anesthesiology and surgery at Vanderbilt University Medical Center and the co-director of the Critical Illness, Brain Dysfunction, and Survivorship, SIBS, and they have their own jackets, and I heard a nice story about that. You should read his work. I know when I was an early delirium researcher, I was reading a lot of his work, particularly in terms of medications and ICU delirium, and just learning a lot about how we think about these agents in older adults with delirium in particular. The other thing that's important that you might not see in his bio, so read his bio. First of all, he's been led or co-led several very large NIH trials. He's also expert in a clinical trialist, and he'll be giving a webinar, so please go to the NIDUS sites. Liz, I don't have those in front of me now, but we can maybe announce that at dinner, but there is a clinical trial webinar series that Pratik will also be leading a talk on, so please come to that, because he's really also, besides being an expert in pathophysiology, is an expert in leading very large RCTs and clinical trials, so beware of that. The other thing to know about Pratik is he's I think it's rare to really have an anesthesiologist that's a delirium champion, and he's really a champion of delirium, a champion of delirium societies, including being president of the American Delirium Society and being a champion mentor for people for delirium. So thank you, and thank you for contributing your time to the boot camp.
Thank you. So I'm going to start with two little stories, one about my mentor and one about a mentee. Now, my mentor is not here. He's exercising right now. But Wes told you all about, well, he sits and reads while he's working out. So he's got his music going on. He's got his iPad with some papers he's reading. So I guess he's working. But I know he's there working out with Ed now, Mark Antonio. Both of them are working out. But he told you all the story about how he had to talk to Sharon multiple times or call Sharon multiple times. And he forgets to tell you the second part of the story of how I had to camp out of his office for about 8 hours on a particular day trying to get hold of him. So I had sent him numerous emails saying, new faculty interested in delirium research and sedation, and his assistant blocked me for numerous times. You know, Wes is busy, he's out of town, out of the country, and it's possible that that was all true, except that I just couldn't get in touch with him. So I decided one day that I was just going to find his office in the health service research and camp out over there. So I showed up in the morning, and his assistant, as she has told me numerous times, he's in the ICU. So I said, at some point in the day, this guy has to come back to his office. And sure enough, about 1 o'clock in the afternoon, Wes showed up after MICU rounds, and rest is history. We've been partners now, well, my mentor first, and now my partner for many, many years. So this was in early 2002 or early 2003. The other part, just to put her on the spot, is Tina Bonsig. It's her birthday today, so happy birthday, Tina, and great to come and celebrate over here. All right, so with that, I'll get started on pathophysiology so that you all can get to your dinner on time. And I'm really no expert on pathophysiology because I don't think anyone really knows the real pathophysiology of delirium. There are a few models that are being considered, and that is what I'm going to try and highlight today. Quick thing about disclosures. I have a research grant from Hospira, which is in conjunction with the NIH. So the National Institutes of Health supported my RO1, which is a comparative study, an RCT of dexmedetomidine versus propofol. But they asked me in my first revision that why should we pay for the dexmedetomidine? Find someone else who pays for the dexmedetomidine. And who do you think would pay for the dexmedetomidine? The company that makes dex. So they supplied study drug while NIH supported the salary, etc. So that's a disclosure. We won't be talking about dexmedetomidine in any slides today. So I'm going to focus on the prevalent models. The goal over here is to provide you all with a broad overview. It's not to try and get into all the details. I'm going to try and focus on the critically ill, not necessarily all ICU patients, but patients who are sick. So many of the post-operative patients also who have large major surgery, they are sick patients. So critically ill from that standpoint. And I'm going to try and focus on those that at least have some element of human data or supportive data that we can say, this is plausible that these are mechanisms for delirium in the ICU. Now, hopefully this can project well, but these are the 7 areas that I'm going to focus on: the neurotransmitter hypothesis, aging, inflammation and coagulation, endothelial dysfunction, the neuroendocrine hypothesis, oxidative stress, and network connectivity. And if you'll read review articles of this, some portions of these may be present, there may be other names given to it, but these are the 7 concepts that I'm going to try and discuss during the next half an hour or so. So Dr. Maldonado has numerous review articles, and in each article he tries to up himself by trying to make a more complex diagram than his previous one. This one, I think, is a step back for Jose, which he's tried to simplify something as compared to his previous diagram, which many people show, which has multiple connections showing how these things are all interrelated. And that's really important. We heard Tom talk about biomarkers, and often people study biomarkers with one biomarker at a time. Is CRP associated with delirium? Well, it may be associated with delirium, but what happens to the IL-6? Does procalcitonin have a level? What happens to protein C when IL-6 goes up? All these things don't come in isolation. The endothelium gets affected by inflammation. Have you factored in endothelial biomarkers? So at present, we are trying to look at individual biomarkers and outcomes, but at some point, we're going to have to understand what feeds into what. Is there mediation? Is there interactions, etc.? All these need to be studied. One way of thinking of it, and this is a simplified diagram for Jose at least, is that you have precipitant factors. These precipitant factors then cause some substrate problem. So either then this results in some neuronal aging, you might have inflammation based on either neurodegeneration disease earlier on, or then an inflammatory process that you're having right now, oxidative stress, some neuroendocrine dysregulation in states of stress, etc. You may have circadian dysrhythms. Ultimately, all this leads to a system integration failure, and that leads to delirium. The system, and basically the neuronal system, is not integrated as it's supposed to be integrated, and that results into this disintegration and then manifests as delirium. So let's start with the first one, the monoamine hypothesis under the neurotransmitter imbalances, and we'll then also talk about the cholinergic hypothesis. So one thing to remember is that serotonin, dopamine, norepinephrine, these all may play a role in delirium. Now, the amino acid precursors of these neurotransmitters are regulated and compete for transport across the LAT1 transporter at the blood-brain barrier. So levels of the amino acids, as they compete, reflect in neurotransmitter imbalances in the central nervous system. And this has been established through animal models in many, many publications. So basically then, tryptophan, for example, is the precursor of serotonin. Tyrosine, phenylalanine, a precursor for dopamine and norepinephrine. And there's competition over here. So if higher levels of tryptophan are present, you might have more serotonin, but at the expense of dopamine and norepinephrine. So think about it conceptually from that standpoint, that these amino acid precursors limit or augment which neurotransmitters are going to be in excess or depleted based on which one is being able to get through that LAT1 transporter. And supporting this hypothesis that these neurotransmitters and their amino acid precursors might be associated with delirium are a number of studies which have looked at the role of tryptophan in outcomes. So here are 4 publications that I've shown, and there are more, showing that the levels of tryptophan may be associated with delirium. Now everyone remembers sort of having turkey over Thanksgiving, being somnolent the next day. In a dysregulated system, perhaps having problems with tryptophan depletion or excess might be associated with delirium, or that somnolence, that lethargy, that inattention that comes with delirium. And here are some of the explanations that people at least hypothesize. Again, there's no proof except for a couple of studies which have looked at urine biomarkers of serotonin. So one mechanism could be that you have tryptophan. At high levels of tryptophan, you have more serotonin. With greater serotonin, more melatonin. And as you have more melatonin, more somnolence, etc., which might be a manifestation of inattention. There are other studies which have looked at low levels of tryptophan. This production of this dimethyltryptamine, which is a neuroexcitatory product, causing excitation and hyperactive delirium. And in these studies, which have looked at this, and this is by Lewis, in these patients with hypoactive, they found high levels of melatonin in the urine, and in these hyperactive patients, they found low levels of melatonin in the urine, suggesting that this pathway might be going down these two alternative routes. Another area of interest in tryptophan metabolism is that majority of tryptophan actually does not go down this pathway that we just talked about, but a lot of tryptophan metabolism goes down through the kynurenine pathway, and the kynurenine pathway is where metabolism occurs specifically in inflamed states or when patients are sick. So if tryptophan then breaks down to kynurenine, it has two alternatives. Either you have protective kynureninic acid, or when you have inflamed states and in sepsis, etc., kynurenine breaks down and goes down this pathway to quinolonic acid and neurotoxic effects. And there is at least some data again suggesting that the levels of kynurenine are associated with worse delirium. And this is a study that we did a couple of, now 8 or 10 years ago. And this was interesting. This is a medical student of mine who I was working on tryptophan metabolism. And she said, you know, this is great. You have this hypothesis of it making more serotonin, this and that. Have you looked at the kynurenine pathway? Because I talked to someone who was a mentor in undergrad, and he's told me that that's the pathway you should concentrate on. If you have samples, I'd like to go down that route. And you know, she is now a well-funded researcher. She turned out to be an endocrinologist later on. She didn't follow me in critical care. But we published this in Critical Care Medicine. And what it shows is that if your kynurenine level increases, your days without delirium and coma start going down. So your days without delirium and coma decrease as your levels of kynurenine increase. The other aspect in the neurotransmitters looking at the cholinergic pathway, and the important area, sorry, I keep blocking your view over here. Part of the cholinergic pathway, important areas is arousal and attention, memory and cognition. So these are areas obviously that are affected in delirium. And some of the studies that have tried to look at whether the cholinergic pathway is associated with delirium have been based on trying to map out where cholinergic pathways are predominant and where lesions with delirium are also predominant. So this is a study which has mapped this out. So this is a review article by Shea. The arrows over here show the cholinergic pathways, where there are rich cholinergic pathways. What you have in dark gray over here are studies with patients with delirium where they found neuroanatomical lesions in those areas. In light gray are areas that are associated with attention. And you can see this overlap in the prefrontal cortex, in the parietal area, sort of in the hippocampal area, as well as in the temporal area, that where there are rich projections of cholinergic pathways, there are also associated deficits seen on neuroradiological findings in patients with delirium. So at least a mapping of where cholinergic pathways are rich, that you have those lesions in patients who have delirium or altered mental status, suggesting that there may be a role of these pathways again in delirium. Studies looking at that, the number of studies looking at anticholinergic burden, etc., sort of trying to see if you have low levels of acetylcholine, how those are associated with delirium. And a number of studies have looked at this association of postoperative delirium with raised levels of anticholinergic drugs. And you can just look at this list over here, again suggesting that there may be a role of the anticholinergic sort of pathway or the cholinergic hypothesis in delirium. Now, one RCT has been conducted to try and look at this, and this was the rivastigmine study with a goal of trying to increase acetylcholine. That study had to be prematurely stopped because as patients were given rivastigmine, the mortality in the subgroup in one of the DSMB analysis was higher in the group that was given rivastigmine. So while this hypothesis is still being held, treatment with something like rivastigmine to increase acetylcholine has not been shown to be associated with improved outcomes. Part of all this sort of points to the fact that none of these mechanisms occur in isolation. So we may be able to impact the levels of acetylcholine, but it's possible that the particular patient group that we are looking at, this may not be the hypothesis for their delirium. They may be having delirium because of some other mechanism, And mechanisms of delirium, again, don't happen in isolation. If you could say that this group of delirious patients is because of the cholinergic pathway and this group is because of inflammatory, then we could target therapies. The part of how to separate that is still not clear. With regards to neuronal aging, a short sort of blurb over here. Basically, with aging, and you have neuronal aging, you have problems with blood flow, you have problems with neuronal loss, and the signaling between various systems also fails. A lot of studies have looked at atrophy with delirium, and I'll show you some slides showing that if you have neuronal loss and atrophy, that is associated with delirium. As one study looking at risk of delirium and age, and this is a study that we did a number of years ago, so 2006, and what we showed was that the probability of delirium in the ICU increases significantly as you start getting beyond the age of 65. So it stays relatively sort of linear over here, but a sharp increase as we go up over 65 years of age. In the brain ICU cohort, which Wes had talked about, this was the large study that we did, observational study looking at long-term cognitive impairment after critical illness. There was a small cohort of patients embedded in that, so nested within that study, that we did MRIs at discharge and MRIs 3 months later. Now, none of these patients could get MRIs before they came to the ICU because none of these ICU admissions were planned, and so no MRIs were done before. And in this study, what we're looking at in this column over here is MRIs at discharge. This column, MRIs at 3 months. The top graph is hippocampal volume. The lower graph over here is superior frontal lobe. The x-axis is days of delirium. Y-axis is volume, okay? So if you just focus on the 3-month outcomes, as your days of delirium go up, your volume in the hippocampus in this association study was lower. As your days of delirium go up, volume in the superior frontal lobe was lower. Now, I cannot tell you whether these patients came with atrophy and therefore got delirium, or they had delirium and therefore they had atrophy in these areas 3 months later. What's interesting is that of all the regions of interest that we looked at, the superior frontal lobe and the hippocampus were the only 2 areas which showed loss of volume or increase brain to ventricle ratios, which again maps to areas that are seen in delirium, right? Superior frontal lobe associated with attention, hippocampus associated with memory. So it wasn't like a global atrophy, but seemed to be atrophy in certain areas which map to the features that you see in delirium. So in systemic neuroinflammation, Dr. Inoue went over this briefly when she gave her talk. But just to go over it again, if you have systemic inflammation, whether you have surgery or you have sepsis, that can result in an inflamed state. You have blood-brain barrier permeability problems. You might have inflamed neuroinflammation. You have microglia. Those then get activated. You have a cholinergic inhibition of this. So this is work that Kevin Tracy has done showing the cholinergic pathway which inhibits some of the inflammation. And again, this is where the cholinergic pathway and the inflammatory pathways, or those 2 hypotheses, link. So if this pathway is not working, this inhibition may not occur and these microglia may get even more activated. So think about that in normal situations, when you have this inflame of the microglia, the cholinergic inhibition will try and damp that down, and perhaps that helps with your delirium being resolved. On the other hand, if you're older, if you are on a whole bunch of medications which prevents you from having that cholinergic inhibition being put into place, what you might have is these prime microglia then become really overactive, and you have the resultant delirium either being a prolonged delirium or putting you at risk for longer term cognitive impairment after that. Again, it's a hypothesis which was published. If you look at individual elements of this, whether you're looking at TNF, whether you're looking at any of the interleukins, procalcitonin, and C-reactive proteins, etc., all have individually been studied to see whether any of them are associated with delirium. And just 2 graphs that I'm going to show you all over here. This is looking at TNF and probability of delirium on the y-axis. And what you see is that as your level of TNF goes up, your probability of delirium on the y-axis goes up. Protein C has an inverse ratio. When you are septic, when you're sick, you have low levels of protein C, and when you have low levels of protein C, you tend to have microthrombi, and that might result in perfusion abnormalities, etc. And so when you have low levels of protein C at this part, as seen on the x-axis over here, your probability of delirium is higher. As your levels of protein C go up towards more normal, your probability of delirium goes down. Again, studies done in isolation with one biomarker at a time, and it's not looked at how all these things play together. Right, let's switch gears to endothelial dysfunction and the blood-brain barrier. And this is an interesting concept because the endothelium is prevalent everywhere in your body, and it also creates one of the protective layers of your blood-brain barrier. And in sickness, there's concern that you have a leaky endothelium. So one of the hypotheses, and this is Chris Hughes' work, who's one of my former mentees now, he's all grown up now. So you have endothelial dysfunction, and with endothelial dysfunction, what you might have is two things. You might have impaired perfusion. So one thing may be that your blood vessels just are not reactive like they should be, and perfusion is a problem. The second thing is that you may have endothelial dysfunction, which may manifest in some of your markers of endothelium injury being elevated. So you might have both impaired perfusion, and you might have increased permeability of your blood-brain barrier. And if you have impaired permeability of your blood-brain barrier, the possibility of toxic metabolites then making it into your brain are that much higher. So we've looked at both these elements, whether perfusion is a problem or whether these increased permeability and markers of blood-brain barrier injury are associated with delirium. And this is the first study looking at what's called endopath. It's a device that you put on your finger and you inflate a blood pressure cuff way above what is considered normal blood pressure, and you keep it elevated like that for 5 minutes, and then you let go, and you have the same control on your other arm. And the goal is to see how quickly your blood vessels, there's nitric oxide production, etc. How quickly does your blood vessels vasodilate? Lower the levels are better. And what we showed was that in these patients who are critically ill, as your endopath goes up, so higher is better, as your endopath goes up, your adjusted days of delirium go down. Now I'm really sorry that this color of this graph is so garish. This was not how we submitted it to anesthesiology. Anesthesiology was going through a phase where they wanted to send all the data to them, and they would create their own graph to replicate what we had done. And this is the color combination that finally showed up in the proof. And when we objected to the color combination, they said, no, that's what we've chosen. So this ugly looking graph, I don't show it too often because this is not one that I'm really proud of. Other markers that we were looking at endothelial dysfunction and altered blood-brain barrier. So the y-axis over here is adjusted days free of delirium and coma. And this is just one of the things that I just wanted to point out over here, because this outcome, not too many people are aware of why we do these days alive and free of delirium and coma. So in a patient population where mortality is high, one of the ways that you can have short durations of delirium and short durations of coma are if you die, right? So you might do a study where you found that one group had only 3 days of delirium and one group had 5 days of delirium, but the group that had 3 days of delirium were dead and the group that had 5 days of delirium were alive. And if you say which one had the better outcome, if you were looking at duration of delirium, all the dead people had the better outcome, all the people who had 5 days would be worse, right? So when we published MENS, we thought we would be really smart and follow what people were doing with ventilator-free days and come up with delirium-free days. What I didn't think about when I did that, and I applied to the FDA for a change in my endpoint for the study and to the NIH, is I didn't figure out that in delirium outcomes, coma is another confounder. So you could be free of delirium because you're comatose, or you could be free of delirium because you're normal. And if you just say delirium free, both of them are still in the same bucket. One is terrible and one is good. So the newer sort of way that people are looking at outcomes related with delirium are how many days are you alive, which is a good thing, and free of both delirium and coma. Because if you're alive and free of delirium and coma, you are that much closer to being normal versus if you are alive with delirium or with coma. Okay? With all that, the y-axis over here is adjusted days free of delirium and coma. So you want more days alive and free of delirium and coma. And as these biomarkers increase, your days alive and free of delirium and coma, at least in pi1 and in S100B, significantly are reduced. So again, some supportive data showing that either markers of endothelial dysfunction or markers of neuronal injury with S100B associated with delirium. In this particular study with S100B, we were trying to see whether there is an association with inflammation. So we tried to put IL-6 both as interaction term and as a mediator to try and see whether there was any association, whether one resulted in going through a second pathway for the outcome. And we didn't find anything in particular with this particular analysis, but at least a first attempt was made to try and see whether there was interactions between inflammatory biomarkers, endothelial dysfunction, and outcomes. All right, we'll skip the neuroendocrine one. Oh, maybe not, sorry. So the neuroendocrine hypothesis suggests that in times of stress, you have a significant upregulation of your glucocorticoid receptors, and specifically your glucocorticoid receptors in the hippocampus. And once you have this increased glucocorticoid receptors in the hippocampus secondary to stress, you might have mitochondrial dysfunction, you might have cell death, there's some tau missorting resulting in neuronal atrophy. It also feeds into neuronal inflammation, etc. And some of this association between stress and delirium has been again looked at in some observational studies. This is one study which looked at cortisol levels and neuropsychiatric symptoms, again showing that high levels of cortisol were associated with delirium. This is another study that was done by Dale Needham's group, corticosteroids and transition to delirium, again showing a significant association between giving corticosteroids or patients having received corticosteroids in this observational study and a higher probability of delirium. So therefore, it was surprising then when the HYPRESS study came out, one of the things that they were looking at in the secondary outcomes was, while it's true that we may be able to give steroids in patients with sepsis and that might improve outcomes, does it have any secondary outcomes? And what this study showed was, while there was no real benefit in giving steroids for sepsis, it actually had a protective effect on delirium. It's really not clear how all these hypotheses meld together, but low dose steroids in this particular study was associated with a lower level of delirium than some of the other observational studies that we've at least looked at. It was a secondary outcome, so apart from the primary outcome, they had about 15 secondary outcomes. So I'm not going to lay a lot of weight on this. I don't want you all to start treating people with delirium with steroids because it's a 15th number secondary outcome. But just to show you all that these are the data that are available out there. All right, oxidative stress. We've heard about a little bit about oxidative stress earlier on, and where we wanted, this is a study done by one of our group members looking at cardiac surgical patients, and what we wanted to see was whether blood flow disturbances, hypoxia, etc. during cardiac surgery is associated with increased levels of markers of oxidative stress, and whether that was associated with delirium. So we were using near-infrared spectroscopy during cardiac surgery, and we tried to remain the same. Whether there was a group that got hypoxic, and we considered 20% below baseline to be hypoxic. There's no sort of consensus on that, but that was based on what, at least based on the literature that we read, that seemed like a reasonable cutoff. The other part we were looking at was, well, maybe they don't get hypoxic, but we put people in the operating room on 100% FiO2 frequently. Is there hyperoxia, and does that cause harm? And then the third part we wanted to see was, are there patients who have hypoxia? Then we ramp up the oxygen, and then they get reperfusion, and does that cause problems? And we did find very surprising results. This is the odds ratio for delirium. When you look at the worst graph of the highest odds ratio for delirium, it's the group that got hyperoxic reperfusion. That means they dropped their NIRS levels below baseline for below 20%, and then when we did whatever we did, ramped up the oxygen levels, helped them with blood pressure medication, and then they bounced significantly above threshold for a while, that group had the worst outcomes. That group also had the greatest amount of markers of oxidative stress. This is measuring isofurans and isoprostanes, and the group that had the hyperoxic hypoperfusion had the greatest levels of oxidative stress markers. And when this study looked at it through mediation analysis, it appeared that these changes were mediated through the oxidative markers. So you can do formal mediation analysis, and that was at least one signal that the changes in perfusion over here were associated with worse outcomes mediated through the increased levels of oxidative stress markers, isofurans and isoprostanes. I will get you all out at 5:30. We've got one more hypothesis to talk about. So the network connectivity hypothesis basically says that the brain is a well sort of oiled machine which has a lot of connections, and they all work in conjunction with each other, and there's a synchronicity of that. So it's not just randomly going everywhere, but there's an order behind all the madness over there. And that delirium represents a failure in integration and processing of all this information. And some of these problems may have vulnerability state, at least in aging. Now this is one study, and the two of these folks over here, Shaniqua and Syed, who are experts in EEG and NIRS, they probably understand this more. But what this study published in Anesthesiology looked at was what are some of the EEG biomarkers of patients who have delirium. And what they found was that you had decreased functional connectivity, and more importantly, the directionality of information flow, which should be from cortical to subcortical, was reversed in many patients with delirium. So instead of the connectivity or the going in one direction, the signals were going in the opposite direction. And if you'll have more questions about this, you can ask Shaniqua or Syed. But at least as a thought to begin with, that the directionality of flow or directionality of information was in going wrong direction in many of these patients with delirium based on this mean phase lag in the delta band of the EEG. And then that's all I can tell you about EEG, so I'm going to stop there. We have looked at functional connectivity looking at diffuser tensor imaging, and what this is looking at is in the white matter tract, the flow of water in the white matter tract. And what you want is, so you look at fractional anisotropy, and what you look at is in these long connective white matter connective tract, if everything is flowing properly, then 100% should be going through, it should not be leaking, so you should have a ratio of 1. On the other hand, if you have disruptions in your white matter tract, then the water which is going along those white matter tracts leaks out, and your fractional anisotropy would decrease. And what these studies have shown, and again this is from the brain ICU cohort looking at DTI, and what we found was that if you had greater amounts of delirium, your functional anisotropy was much lower. So much more sort of disruption in those white matter tracts, not anywhere closer to the 1 part over here, but much lower, whether you looked at whether you looked at it at 3 months or at 12 months, at discharge or at 3 months. And this was in 2 areas. So the anterior limb of the internal capsule, as well as the genu of the corpus callosum. So the big white matter tracts having problems with functional connectivity, with disruptions in white matter tracts. So at least something that has also been seen in postoperative patients, similar to what we've seen in ICU patients. These are small studies. These are 50 patients, but getting 50 patients into MRIs at discharge after they've had delirium in the ICU, and then again at 3 months to get them back and say, yep, you remember that claustrophobic experience, we're going to shove you back in for this for another 45 minutes. It's not easy, but these are 50 patients who had at 3 months and at 12 months. So I'm going to end by reminding you all that these mechanisms are complex. They don't happen in isolation. So there are a number of authors who've tried to show how these all are interrelated, and it's important to realize that they are. And it also depends on what your precipitant is, what your vulnerabilities are, and all these sort of play closely together. So while we may be understanding certain basic hypotheses which may explain some delirium, it's not easy to base all treatment modalities. So when people rush from biomarkers to interventional trials, we may have to take a pause because those biomarker studies are not universal. It's not that every patient follows through that pathway. So with that, I'm going to end perfectly at 5:30. I have my email up there if you'll have questions. Or you can ask questions now, sorry.
We have a couple minutes
Yeah,
for questions.
yeah.
You did a great job of finishing up.
Oh, thank you. Everyone's like, dinner.
I just had one question.
Sure.
About the first hypothesis, well, the first two hypotheses around serotonin and acetylcholine. I was thinking about a patient cohort I'm seeing a lot lately, which is Huntington's disease, which is predisposed to delirium. And they're treated with two different antichoreic agents, one being risperidone, which is obviously an anticholinergic, and the other being tetrabenazine, which depletes dopamine, serotonin, and isn't an anticholinergic. And I'm wondering if there's any data on delirium rates between those two, given they've got the same predisposing risk factors and the different.
Yeah, I'm not aware. John, anything that you know of?
No.
Sorry.
So I just wonder if that might be able to help delineate. And tetrabenazine. It's an antichoreic, so it's not an anticholinergic, and it depletes dopamine, serotonin, pretty much all of the monoamines. And so one of them you're going to have high neurotransmitter levels, the other you're going to have low.
Do you see any difference in your practice?
I see them as outpatients, so
Okay.
most of them are not delirious when I see them. Yeah, so I'm probably not seeing them at the right time in their clinical course. Yeah.
But I think all good study questions start with questions like this. So this may be something that you can try and take up and check with your colleagues about actually studying this systematically. Yeah, Tina first. Okay, sorry. Birthday girl goes first now.
Thank you for laying that out. I hope this isn't a silly question, but I sometimes have a hard time reconciling how some of these non-pharmacologic practices like light and orientation and wearing your glasses and opening up the windows, how that fits into these pathological mechanisms in terms of reducing the rates of delirium. I guess is there a good way to think about that? Or?
Tina, you're stumping me, so it's not a silly question. I'm not sure any of these, how all these integrate. I'm not sure whether they help with the network sort of, with at the central nervous system, just synaptic connections, with whether some of these orientation exercises, etc., help with that. With the GABAergic agents, etc., there may be something related with excitatory amino acids, with neurotransmitters, so it may be related with that. But apart from that, I think it's all just conjuncture, that either you're not harming someone with some of the agents, or it's just trying to get all the synapses to sort of be integrated versus the other way when you're trying these orientation exercises, getting the hearing aids on, etc., just getting them all the sensory input in the right way versus what's not there. Anybody else? Donna, any thoughts? Okay. Okay, go ahead, please.
I wanted to ask you if, according to all your research, all these theories, they are based in the original organic condition that triggered it? So what I mean is, you say that there will be different patterns in the way people, so in the pathophysiology will be diverse according to each kind of patient's cluster, I would say. So do you think these theories came because there was a set of patients, like post-operative patients, fracture patients, and then a theory will fit in them? Or do you think, how do we will get these cluster-related pathophysiology in order to prevent it or to manage it? So what's the goal of knowing which pathophysiology pathway is describing that patient specifically?
Go ahead.
Piggyback on that question.
Yeah, or answer it too. Yeah.
The same hypotheses, right? Systemic inflammation, inhibitor dysfunction, blood-brain barrier breakdown, cholinergic hypothesis. also is in POCD, right? And we saw earlier today that there's actually not very much overlap when you actually assess these patients in that middle of the pie Venn diagram. You know, while the same pathophysiological changes are happening, they seem to be distinct, or they're emerging as a distinct set of diseases. So it's the same, another side of the same question.
So, I mean, you know, initially the thought was whether the cholinergic hypothesis was the final common pathway. And I think there are a number of studies which have shown that probably that is not the case. I think the present thinking is that the common link in all this is inflammation. And with how all the, you know, whether it's through medications, etc., all that results in an inflamed state, and that probably results in delirium. I think that is a fair amount of thought, at least based on some of the animal model work going on. And with regards to this link between early inflammation, delirium, and POCD, etc., some of the work that's now coming out of Lars Rasmussen's group, and they did some of the earlier works on the ISPOCD, is whether there is distinct patterns of patients who have persistent inflammation versus those whose inflammation gets resolved during the early hospitalization state. And so if you look at that Venn diagram, and you know, it all these biomarkers, when we should be measuring biomarkers, that's another $1 million question, right? I mean, is it day 135, that's what many studies do, or is it later on? And at least some of the data are suggesting, and it's again too early, is that a lot of people have this inflammatory state, but by day 7, day 10, majority of them have got it ramped down or dampened down, but there's a group that has persistent inflammation. Perhaps that group is the one then has it further down. So that's at least related to inflammation, and these are some data that are coming out. I haven't seen the results, so I'm not 100% sure how that's all going to pan out, but that was at least early communication that I've had with the co-authors. I'm not sure whether we're going to have distinct patterns that certain patients, like the septic cohort with delirium, is going to be this way, or but there may be certain subtypes. You know, there may be, with the hepatic patients, there may be a pattern that when you see hepatic encephalopathy delirium, that may look something like that because they are more similar in many ways. So there may be smaller patterns that might come out, but right now I think it's still something that we just don't know.
If I may, I think that to a large degree, as we measure delirium, what we are seeing is a behavioral inability to mount an appropriate response to an external stimulus. That's how we see it externally. And that is a manifestation of the brain's inability to mount an appropriate response to the stimulus that it's receiving. And I suspect that there are multiple pathophysiologies or multiple disturbances that impair the brain's ability to mount that appropriate response. So whether it's by inflammation, by blood-brain barrier disruption, by neurotransmitter imbalance, there's it kind of lowers the threshold for disruption of that appropriate response, and that's perhaps why we see sort of what's somewhat of a homogeneous, in a way, a homogeneous manifestation of what's probably a very heterogeneous underlying problem. That might explain why the behavioral, where there's sort of like a central behavioral manifestation, why things like orientation with regular stimuli or light and sleep regulation actually helps these behavioral changes even in the face of disrupted physiology.
Good. Yeah.
My question is, what role do you think plays the histaminergic system in delirium? The H1 and the H1 receptors, do you think it plays an important role? Or?
I haven't read a lot about that. I mean, you do. I mean, when you use those medications.
NIDUS and, NIDUS and
Graph. Everything in the world causes delirium. With the blockers. Yeah.
And the
Yeah,
yeah,
and it's-
criteria, we've grappled with that because
Yeah.
the evidence is conflicting, but yeah.
I mean, it's definitely possible because H1 and H2 blockers in some studies have shown to be associated with delirium. But again, none of these studies are convincing enough that you can say definite. And that goes with all these hypotheses, unfortunately, because there are you can choose your studies to make it a positive association, or you can find equal number of studies which show no association. And that's one of the biggest problems with what we have right now.